Hello, my name is Patricia Pérez-Moneo, specialist in Gynecology and Obstetrics at the Hospital Virgen de la Luz in Cuenca, Spain. In this video, I'm going to present a series of cases in which we can see how the embolization of the uterine arteries prior to induction of second or third trimester abortions with placenta previa is an effective technique to reduce maternal blood loss. During the second trimester of pregnancy, a large number of placenta previa cases are frequently recorded. Placenta previa is a condition where the placenta is attached in the lower third of the uterus, totally or partially covering the internal cervical os, or being very close to it, that is, blocking the birth canal. As we can see in this picture, on one side we can see the cervix or uterine neck, which is where the fetal exit takes place. On the other side, we see the fetal head, and in front of it is the placenta blocking the fetal exit. This is because uterine growth occurs gradually in the first months of pregnancy, resulting in an exponential growth by the third trimester. Therefore, 90% of placenta previa cases in week 20 will not be placenta previa at the end of pregnancy. Late abortions or second trimester terminations of pregnancy are a common practice in many hospitals due to several reasons, both maternal and fetal. In these cases, induced vaginal delivery with drug treatment is the technique of choice to reduce maternal morbidity. However, in second trimester pregnancies, the existence of placenta previa can hinder vaginal delivery of the fetus and complicated by increasing maternal morbidity due to more severe bleeding and increasing need for blood transfusion or longer hospital stay. For this reason, embolization of both uterine arteries before starting the induction of this type of delivery may reduce maternal morbidity, as we can see in the following cases that I present. The first case is a 37-year-old female patient, 26 weeks pregnant, gravid at 4 with 3 previous vaginal deliveries. A previous diagnosis of growth retardation type 4 being this the most extreme level, an estimated fetal weight less than 400 grams and complete placenta previa. After being approved by the ethics committee, a legal pregnancy termination was performed with prior informed consent of the patient. Her previous hemoglobin was 13.2 grains per deciliter and hematocrit 39.9%. The second case is a 35-year-old patient, 19 weeks pregnant, gravid at 2 with a previous spontaneous delivery, who came to the Gynecology emergency department of our hospital with bleeding similar to menstruation. Ultrasound revealed singleton pregnancy, transfer presentation, positive Childbirth, anhydramnios, and partial placenta previa. She tested positive for preterm rupture of membranes. Blood test results showed 20,300 leukocytes per milliliter with neutrophilia, high C-reactive protein 76 milligrams per liter, hemoglobin 12.7 grams per deciliter, and hematocrit 37.1%. Following these findings, it was decided to terminate pregnancy. The third case is a 34-year-old patient, 20 weeks pregnant, prima gravida, diagnosed with fetal trisomy 21, who requested legal termination of pregnancy. Upon induction of labor, complete placenta previa was confirmed. Previous blood test results with an hemoglobin of 20.4 grains per deciliter. The fourth case is 41-year-old patient, 19 weeks pregnant, gravid at 5 with a history of cesarean section and antepartum stillbirth and 2 late abortions. diagnosed with antiphospholipid syndrome and treated with Clexane 40 mg and aspirin 100 mg every day during the current pregnancy. Trisomy 21 was detected and induction of second trimester abortion was planned. Ultrasound confirmed marginal complete placenta previa. The hemoglobin previous was 10.6 grams per deciliter. The last case is a 24-year-old patient, 23 weeks pregnant, who was referred to our hospital with preterm anorexia and suspected chorioamnionitis with placenta previa. The patient had normal vital signs, fetid vaginal discharge, and little vaginal bleeding. No hypertonus and or abdominal pain were recorded. Ultrasound showed singleton pregnancy, positive hair rate, anirrhapnias, and complete placenta previa. Blood tests revealed 21,500 leukocytes per milliliter, high C-reactive protein, hemoglobin 11.3 grams per deciliter, and hematocrit 32.8%. All patients underwent embolization of both uterine arteries because they presented total or partial occlusive placenta previa. Selective bilateral uterine arteries embolization was carried out with sphingostat via right femoral artery approach. In the first photograph, we can see the catheter introduced through the femoral artery at the beginning of the uterine artery, and when the contrast is injected, the entire course of the uterine artery and its branches is drawn. And in the second photograph, we see after embolization how the contrast stops and the artery is no longer drawn. Then the labor was induced according to our protocol with misoprostol 400 micrograms every 4 hours up to 5 doses, followed by intravenous oxytocin 20 units per 500 milliliters, glucose at 5%, until expulsion of fetus and placenta. The first patients required manual delivery in the operation room and developed a subsequent infection that required the performance of a hysterectomy. 3 of them required subsequent uterine curettage due to the persistence of placental remains. Massive bleeding was not observed at any time in none of them. Subsequent hemoglobins were 12.6, 12.7, 11.3, 10.3, and 10.6 respectively. And 3 of them had a subsequent gestations after. So, induced second or third trimester abortions are a common practice in many hospitals, but the presence of placenta previa at these gestational stages can complicate them by increasing maternal morbidity. According to some studies, the existence of placenta previa is related to a higher maternal blood loss during termination of pregnancy in second trimesters. Despite that, vaginal delivery continues to be the technique of choice, so strategies must be found to perform it with the least morbidity possible. With that time, we presented a series of cases showing that uterine artery embolization prior to induced abortions is a beneficial and safe technique in induced second and early third trimester abortions with placenta previa, resulting in a more effective control of uterine bleeding that leads to a decrease in maternal morbidity. Although one of the patients developed a subsequent infection, its origin was unclear and could not be directly attributable to embolization. So further studies are necessary to evaluate the possible complications of this technique. In this series of patients, test results after the procedure showed a fall of hemoglobin to levels between 0 and 0.9 grams per deciliter. None of the patients presented severe bleeding nor required blood transfusion. In addition, resorbable materials such as sponge are used in this type of procedure, with a 3 to 15 days duration of action, which usually allows future pregnancies. In summary, prophylactic uterine arteries embolizations prior to induced abortions with placenta previa seems to be an effective technique to reduce maternal blood loss and has been added to the protocol for those abortions as long as the technique is available at the hospital. These are the authors of the work. The authors don't declare conflicts of interest, and these are the references. Thank you for your attention.